Right, kids with chest pain. Are you really concerned when a kid comes in with chest pain? What's it going to be? I mean, kids don't get chest pain, do they? Who's seen an infarct in a teenager? Tombstone. I've called it tombstone infarct. So you've got to be a little bit careful in these kids. So this is an 11-year-old girl and she's complaining of central chest pain. It's not here, Dad. It's deep in my chest. It doesn't change when I move or breathe or where you press on it. And my daughter had no past medical history. So what do I do, Dad? You get back in your room and you finish your homework. And I'll talk to you later. Because what are the chances of it being anything? So kids and adults are different when it comes to chest pain. Risk factors are very, very different. We don't usually see this. Okay? We don't have these sorts of rollicking parties. Although I believe that smoking is a little bit of an issue these days. Watch this kid. Look at that. A freaking professional, right? 1 pack a day smoker. So the same risk factors that you see in adults, you don't see in children. So it's not that causes it. That's why most arrests are... I mean, look at me. Okay. Yesterday I was the walking model for the difficult airway, all right? I'm short, I'm fat, I have no neck, I've grown a beard, I've got a poor mouth opening, big in size, there's a melon party 4 when you look in, right? Why do I teach airway? You have no self-preservation motivates me, okay? I am an absolute advertisement for a VF arrest right now, secondary to cardiac causes. However, I had an angio earlier this year, and I've got clear coronaries. So if my wife's still here, all right. So, so if you go to some of the Up to Date and all these, they give you all these causes: idiopathic, musculoskeletal, breast-related. In most kids, it's going to be musculoskeletal. If it's not musculoskeletal, is something happening at school? Is something stressing them? It's going to be a stressor-related response in most kids. There's all these paediatric chest pain things, and they're really rubbishy sort of stuff because it's not going to be that bad. The bad stuff is, they can get obstructive cardiomyopathies and aortic root dissections and pericarditis and all this sort of stuff. It doesn't happen that often. And the 2 cardiac causes, though, that we have to be careful of, one is Kawasaki's disease, and the other one is Al-Kappa. And Al-Kappa is when they've got an anomaly in terms of the origin of the left coronary artery. And that can, in fact, cause ischemic changes in children. Okay? And Kawasaki's disease is... who's heard of Kawasaki's? Has anybody not heard of Kawasaki's? Okay, so fever for 5 days, although the criteria have changed. You don't have to have a lot of the other things now. You can just have the fever for a period of time. So it used to be fever for 5 things and a few of the manifestations, which included strawberry red tongue, red palmar surfaces, what do you call it, lips, anterior cervical chain, conjunctival injection. You don't have to have all those things. The problem with Kawasaki's is that unless you diagnose it and treat it, there's a significant issue with coronary artery disease, and they get aneurysms in this. And quite a famous sort of death, was a Hollywood death with John Travolta's son had Kawasaki's disease when he was younger, and he had actually had a coronary artery rupture and died. So it's real, and we have to be very, very careful in kids because we've got to treat them quickly with immunoglobulin and aspirin. None of the studies have been done to show that aspirin or immunoglobulin are better. They've always been tested together, but it's an important thing to pick up. Pulmonary embolism causing chest pain, certainly in the older children, and if they're on the oral contraceptive pill, and there's all this stuff recently about the oral contraceptive pill causing PEs or causing DVTs in people, there is a small risk. It is small. You can still get some of the other issues with kids that are in hospital, but the chances of them having a PE or a DVT leading to PE is very, very small. There can be other things that predispose you to it. However, again, this is very, very low risk. What I'm trying to tell you is chest pain in kids, unless you start thinking about Kawasaki's and anomalous commencement of a coronary artery, is not going to be that prevalent. This is one you need to be careful of, though. If they come in with chest pain and they've also got a fever, we've got to be a little bit careful of sickle cell disease kids. And in these kids, they get this acute chest pain syndrome, and it actually occurs secondary to pulmonary infiltrate. Now, you can also get chest pain that is bony pain in kids that are secondary to all sorts of malignancies. Even the blood-borne malignancies can cause joint pain and bone pain. So you've got to start thinking about those as well. But the incidence is very, very low. And so, in conclusion, so this is like a 5-minute lecture, if you're young and you have no real medical history, and the medical history we're thinking about is, do they have Kawasaki's, have they had congenital heart disease diagnosed, you're going to get a lot of these kids that have had operations at a very young age. In those, there's a higher risk. But if you get a kid, unless they come in with significant ECG change, you do not have ischemic chest pain in kids. And I will say, unless there's sickle cell disease or the left coronary artery anomaly, or they've had Kawasaki's, in kids that are about 7 or 8 or 9 or 10 years old or younger, the chances of it being anything significant are very close to 0. All right? You should learn how to read paediatric ECGs, because they are very different in terms of what happens to the T wave. And there's a blog I've written on resus.com.au that goes through the paediatric ECG in detail and shows you how to read it, because sometimes you can get some issues with it. And I've seen ECGs presented to me with T-wave inversions of particular groups of kids where it's normal for it to be inverted and people are concerned about ischemia. So have that little bit of knowledge, because that's important. And I think that's all I have to say. All right? It doesn't happen. All right, thank you. Nice.
Fantastic, thanks, Pete. Just quickly, Pete, before you leave the stage, because you like putting me on the spot, so I'm going to put you on the spot.
Can I just say that was Shane that did that? Yeah, put me on the spot.
We'll talk about that later. Pneumothorax in these kids. How often do you do a chest X-ray?
I don't do a chest X-ray unless I find something clinically in kids and unless they've got some other condition. So if they're an asthmatic and all of a sudden they're decompensating in some way and I'm concerned, then I do it. I mean, otherwise, I'm quite averse to doing investigations in kids. I really don't do very much at all unless I find something in my clinical exam to support it, or I'm suspicious of something. So you get a kid that comes in, they've got chest pain and they're an asthmatic and they're now quite sick and they've been breathing up quite hard. Well, I think about a chest X-ray, won't I, in chest pain. If they've got a fever and they've got a cough and it's productive, well, sure, you know. But the sort of chest pain I'm talking about is coronary syndrome type pain or pulmonary embolism type pain. The rate of dissection, unless the kid has got a congenital abnormality like Marfan, so they don't get dissection until they're much older, because the dissection comes from valvular disease, you're not going to find it in the very young. It happens in the elder group. So I don't do many investigations in these kids at all. I'll do an ECG, I'll interpret it, I'll watch the child, I'll give them some analgesia, I'll talk to them, I'll ask them what's happened at school, I'll say, you're having a hard time, is anybody giving you a hard time at school, are you being bullied, do you want to go to school, is there something going on? And I will tell you, you discover strange things and kids go, well, I don't want to go to school tomorrow. So I've had kids present to me with things like, I can't lower my leg. Leg is stuck in that position, right? And they're in the car and their legs are stuck in that position. And people say to me, well, what's wrong with them, Pete? There's nothing wrong with them. You just got to talk to them, settle them down a little bit, talk to them, find out what's stressing them. And you talk to them and you relax them and they forget and their legs bend and they go back down. In a lot of these younger kids, stressors are the issue. School is very stressful for our children. And I think it's important to say something about that. We all are busy. I work 7 days a week. I mean, I finish here tomorrow night. I wake up at 4 o'clock on Monday morning. I'm jumping on a plane going to work, right? So we don't have time for our kids, but there are some things that we do need to ask, because the last thing you want to do as an emergency physician seeing your kid for some stressor you haven't picked up. That's the father in me talking. So that's all right. That's all good. All right, good, done.
Pete, there's just one other group that I would mention in certain urban environments, is the teenager who's using cocaine.
Yeah, well, certainly.
They're the ones I've seen who do have vasospastic ischemic chest pain, or even aneurysmal chest pain from taking far too much coke.
But that will come in, though, with some signs and some symptoms, and they'll be significantly tachycardic, they'll be significantly agitated. So I've certainly treated a 17-year-old with cocaine, $10,000 of cocaine between 3 young girls when I was at RPA, I remember. I was just amazed. How do you get $10,000? Dad's very rich, right? They came in tachycardic, just hyperstimulation, you know, sympathetic drive out of control, and you do an ECG because they're the ones that can get something. The problem is, though, if you're concerned about what's the rate of those people getting it, very, very low in the young group, and very, very low even in the older group. And I think it's less than 1%, isn't it?
Well, it depends on your age and your chronicity of your use. So in a one-off use, it's very, very low.
Yeah.
But the more chronic your use, the more likely it is it'll happen, because you actually get a cocaine-induced cardiomyopathy, which then increases the oxygen demand of your heart, which means the vasospasm has a greater and more profound effect on ischemia later on.
And the
But you have to
older
be at
you are,
least 19.
If you have ischemia and you're pumping your heart at a rate of 120 all the time, you're going to produce more ischemia. So the older you are, the worse it's going to be. But in kids, you'll see other signs with it. They won't just come in with chest pain. They'll be tachycardic, they'll be hyperstimulated, they'll have the sympathetic response. You'll pick it up. And you've got to ask them the questions. And remember, you're not there to judge them, you're there to treat them. That's the most important thing.
So you can imagine how hard at dinner it is to get a word in between these two. But anyway,